Good afternoon to everyone. Welcome to this webinar series organized by the ERN GUARD-Heart. My name is Gianfranco Sinagra. I am professor of cardiology at University Hospital of Trieste and director of cardiothoraco-vascular department. And since January, I am also the president of the Italian Society of Cardiology. I'm very pleased moderate today's session. Thank you for joining us. ERN GUARD-Heart is dedicated to improving access to diagnosis and treatment for patients with rare and low prevalence cardiovascular disease. This condition requires expertise, collaboration, and strong international networks. Through initiative like this webinar series, we aim to share knowledge, encourage discussion, and strengthen cooperation across Europe and beyond. Today's webinar focuses on an important and very interesting topic, the relationships between myocarditis and cardiomyopathies. We are honored to have two distinguished speakers with us today, Professor Estelle Grandi-Bach and Professor Mathieu Kern from the Pitié-Salpêtrière Hospital in Paris. They are international recognized experts in the field of cardiovascular disease, and we are very grateful for their participation and for sharing their experience and knowledge with us today. The format of the webinar will include two presentations followed by time for discussion and questions. I encourage all participants to actively engage, ask questions, and share comments. Before we begin, I would like to thank the speakers for their time and contribution, and also thank all of you for being here today. Now, without further delay, it is my great pleasure to give the floor to our first speakers, Professor Grandi-Bach. Please.
Thank you very much. I'm very pleased and grateful to be here today to participate in this webinar dedicated in myocarditis and the relationship between myocarditis and inherited cardiomyopathy. So we'll perform the first presentation to present what we know about the relationship between genetics and myocarditis, and then my colleague and friend Mathieu will address the question of recurrent acute myocarditis. So I will begin with a clinical case of a young woman that we had to manage now 10 years ago. She had 31 years old woman. She had absolutely no family history of arrhythmia or cardiomyopathy, and she presented with electrical storm, sustained VT, aborted cardiac arrest, and she developed a cardiogenic shock. She needed circulatory mechanical support. And the ejection fraction was very low at the beginning, but in the context of electrical storm, and she had a spontaneous recovery of left ventricular ejection fraction to 50% after 3 days. And at this time, no endomyocardial biopsy was performed. She had a lot of PVC. And you can see the MRI that was performed 3 days after she came at the hospital, showing a very large area of edema within the left ventricular wall. And this very, I don't know if I can say very specific diffuse subepicardial LGE with a ring-like pattern. And she had a lot of fibrosis, and this aspect of the MRI make us suspect maybe an underlying cardiomyopathy, because we had another patient with this kind of MRI carrying DSP mutation. And so we decided, because we found maybe she had an underlying cardiomyopathy, to implant, against the recommendation at this time, a subcutaneous ICD, because we thought that the risk of recurrence of VT was very high. You can see here the ECG that show a very important microvoltage in all the leads, also suggestive of underlying cardiomyopathy, and we perform a genetic testing showing a definite DSP pathogenic mutation, truncating mutation. So this patient, she had DSP cardiomyopathy, but the first manifestation of the disease was acute fulminant myocarditis. 2 years after, she had a recurrence of electrical storm that was managed by epicardial VT ablation, and until now she's doing very well. So it was the first case in our center that where we show this relationship between inherited cardiomyopathy and arrhythmogenic cardiomyopathy and myocarditis, and we began this work with systematic genetic testing of all patients coming to our institution with acute myocarditis and with a sustained ventricular arrhythmia or right ventricular abnormalities suggesting of an underlying VC. And we find pathogenic or likely pathogenic variant, mostly in desmosomal gene in more than 50% of the patient. So we show that you have a definite link between acute myocarditis, ventricular arrhythmia, right ventricular abnormalities, and a desmosomal gene mutation associated with arrhythmogenic cardiomyopathy. And this association between RVC and inflammation have been described 30 years ago by Guy Fontaine, that reported 3 cases of patients with advanced RVC with hyperacute fulminant myocarditis and lymphocytic infiltrates. And at this time, what Guy Fontaine said is that RVC patient may have a particular susceptibility to infection, because it found that maybe there were some kind of relationship between viral triggers and underlying inherited cardiomyopathy. We have also several studies on RVC showing that within a patient heart, you have an increase of cytokines, and in animal model that carrying pathogenic desmoglein 2 and plakophilin 2 mutation, you see that you have also an increase of inflammatory cytokines within the heart of the mouse carrying this mutation. So you have this relationship between RVC, desmosomal mutation, and inflammation that has been shown in different ways. You have some of case series and clinical cases that showed this relationship between right and left arrhythmogenic cardiomyopathy in patients carrying desmosomal mutation. And in this case series, the most prevalent gene that has been associated with acute myocarditis is definitely DSP. In the other side, if you look at the RVC or arrhythmogenic cardiomyopathy cohort, you can see that a small percentage of patients present an active phase. In this study, including more than 500 index and relatives with arrhythmogenic cardiomyopathy, 4% of the patients presented the active inflammatory phase, and it was more frequent in children. And if you look at the most prevalent gene in patients with this inflammatory out phase, DSP was definitely the most prevalent gene. In patients with DSP cardiomyopathy, it is very recent data from the DSP Eredos network. 17% of the DSP carriers have an acute myocarditis, and it is the first presentation in 60% of the patient. And 32% of the patient with acute myocarditis had recurrent myocarditis-like episode. And most of these patients had truncating DSP variants. So the relationship between arrhythmogenic cardiomyopathy, desmosomal gene mutation, and acute myocarditis, I think, is very well established. But one question was, what is the prevalence of inherited genetic variant associated with cardiomyopathy in a cohort of patients with acute myocarditis? And one of the most important study is this data from the UK and the Netherlands cohort, including more than 300 cases. And it was all patients with acute myocarditis, and they found that 8% of the patients carried a likely pathogenic variant in either a DCM or ACM associated genes. And when I saw the study, I was a little bit surprised, because the most prevalent genes are not ACM genes and not desmosomal genes, but are DCM gene, especially sarcomere genes. And the most prevalent gene in this cohort is the titin genes. And sarcomere genes and DCM-associated genes are more frequent in patients with acute myocarditis presenting with low left ventricular ejection fraction, and desmosomal gene mutation are more frequent in patients with acute myocarditis and a preserved left ventricular ejection fraction. So you can see the distribution, but if we have the major gene of acute myocarditis in this cohort is the titin gene. Another question is, all clinical presentation of patients with acute myocarditis the same chance of carrying a pathogenic or likely pathogenic variant? And one of the answer come from this very important meta-analysis from Monda that was published 2 years ago. This meta-analysis included more than 500 patients with acute myocarditis that had genetic testing. And the first important information is that the rate of pathogenic or likely pathogenic variant in inherited or in cardiomyopathy associated genes is 14%, which is quite high. But the rate of underlying pathogenic variant was much more frequent in patients with complicated myocarditis, especially in children, and the rate of underlying pathogenic variant was only 4% in patients with uncomplicated myocarditis. So you can see that the prevalence of the genetic variant vary according to age, more frequent in children than in adults, and according to the clinical presentation, because it's more frequent in patients with complicated myocarditis. And what is a complicated myocarditis? It's an acute myocarditis with ventricular arrhythmia or with a low ventricular ejection fraction. Another important information is that the distribution of genes seems to be different between the clinical presentation. In patients with an uncomplicated myocarditis, you can see that the desmosomal gene mutation are the most frequent. And in patients with complicated myocarditis, sarcomeric gene mutation are much more represented. And it's a little bit confusing because you can see from the previous report that desmosomal gene mutation may be also associated with severe case of acute myocarditis. In patients with recurrent acute myocarditis, we don't have so much data, but from the case series and small cohort that has been published, the rate of an underlying pathogenic or likely pathogenic variant is very high, more than 60%, and the most prevalent gene in this case of recurrent acute myocarditis is DSP, but you can see that in some cases Titin and PKP2 gene has been also reported. So based on all this data, the last ESC guidelines on the management of myocarditis included the genetic testing into the workflow of diagnosis of myocarditis. It was not recommended in all patients with myocarditis, but in a lot of patients with myocarditis that included patients with a family history of myocarditis of inherited or suspected cardiomyopathy, patients presenting with severe ventricular arrhythmia, patients with a significant LG or persistent systolic dysfunction, and patients with recurrent myocarditis. One remaining question is, are patients with acute myocarditis who carry an underlying pathogenic variant are higher risk than other patients? We have some data from the UK and Netherlands cohort showing that if in patients in which a genetic variant, a rare genetic variant was identified, the all-cause mortality was higher. So this data suggests that acute myocarditis associated with cardiomyopathy associated variant may be a higher risk of complication and mortality. In this other cohort, they showed that patients with acute myocarditis associated with a desmosomal gene mutation, so it was not any mutation, but desmosomal gene mutation, especially desmoplakin mutation, were associated with a higher risk of ventricular arrhythmia during the follow-up and a higher risk of myocarditis recurrences. But maybe we can discuss that after. In preliminary data from the amphibia cohort that is led by Mathieu Kernes, we did not find any difference in prognosis between patients carrying likely pathogenic or pathogenic mutation or not, or with a negative genetic testing. So I think that probably we need more data to look at the prognosis of acute myocarditis associated with an inherited cardiomyopathy. And maybe all the genes are not associated with the same prognosis. As we can see in DCM, we know that in DCM, not all genes are associated with the same risk of ventricular arrhythmia or left ventricle or heart failure, and maybe it is the same thing in patients with acute myocarditis. The identification of pathogenic or likely pathogenic variant in cardiomyopathy-associated gene have a very important impact in the patient and in the family. So I think it is very important because if you identify an underlying inherited cardiomyopathy, you have to make some family screening and genetic screening of the relative that can be a risk. So you have a lot of consequences for the family. For the index patient, I think it's also a lot of consequences, because maybe you will have consequences on the long-term treatment, and in most patients in which we identify an underlying genetic variant, we keep them on beta blockers. You can have an impact on the delay and the level of sport activity. For example, if you identify a desmosomal gene mutation, you will have an impact of return to sport activity, and you will advise to lower the sport activity and to avoid competition. And you will have also some consequences for ICD decision, especially in patients presenting with ventricular arrhythmia during the acute phase of myocarditis. From the last guidelines, what was proposed is patients with acute myocarditis presented with ventricular arrhythmia to wait for recovery with a wearable cardiac defibrillator, and to have risk stratification 3 to 6 months after the acute phase, to look if the patient still have some additional risk factors. And one additional risk factor what was included in the risk stratification is the genetics, because if you identify a gene high risk, like desmosomal gene mutation, filamine, or lamine mutation, then you need to do some gene-specific risk stratification, and probably the threshold to propose an ICD in this patient will be lower, because we know that this patient have probably a higher risk of ventricular arrhythmia recurrence. So you will have a direct impact on the decision for ICD implantation. And you may have a consequence for the immunosuppressive therapy. I think Mathieu will discuss that more in details, but based on this very recent data in patients with DSP cardiomyopathy, you see that patients with DSP mutation presented with myocarditis have a worse prognosis than patients without myocarditis. And what was very interesting in this observational study is that patients treated with immunosuppression had a better prognosis that patient not treated, especially on the rate of recurrence of ventricular arrhythmia. So maybe there is a direct impact on immunosuppressive therapy in this patient with arrhythmogenic cardiomyopathy associated with DSP mutation presented with acute myocarditis. I would like to finish with a clinical case that show that illustrate that things are not so simple in many cases. It's a very interesting case of a fulminant myocarditis in a young man. He had a very family history of acute myocarditis during COVID infection in his monozygote twin, and he had also a family history of cardiomyopathy and severe family history because one of his cousins had a heart transplantation at age 9. So he presented with a first fulminant myocarditis during a COVID-19 infection. He was treated successfully with prednisolone with a good recovery of the left ventricular ejection fraction. And he had a recurrence 2 months after during enterovirus infection, and then he had a very bad outcome. He developed electrical storm, cardiogenic shock, and finally he needed a heart transplantation. And what show the explant pathology of the explanted heart was giant cell myocarditis. And in parallel, we performed genetics testing showing a pathogenic variant in the titin gene. So in this patient, you don't have one cause, you have several causes, probably viral, genetic, and immunologic. And so one of the main message that is that we have to be very systematic in order to find the cause, because you can have the interrelation of different cause, even if a genetic cause is identified. So thank you very much, and I will let Mathieu speak about recurrent myocarditis.
Thanks a lot for this very exhaustive and comprehensive presentation. Many fields remain controversial, but we will discuss after. And now we proceed with Professor Kern that will present.
Thank you. Thank you very much. I will put that. Okay, I think it's good now. So good afternoon or good evening, everyone. Thank you very much, Estelle, for setting the ground of this presentation on recurrent myocarditis. And thank you, Gianfranco, for the wise words about sharing experiences. Because obviously, on recurrent myocarditis, there is not a lot of published paper, not a lot of guidelines on how to manage and how to treat these patients. So I will not focus during this presentation on the genetic aspect of recurrent myocarditis. I think Estelle did that perfectly. I will review during this presentation the epidemiology, the risk factors for recurrent myocarditis, some emerging genetic data, and I think we can discuss also how to manage these patients. So I have no disclosure on this presentation, but let me start by a few words of definition. So this is the 2025 ESC guidelines on myocarditis. There is only two mention of recurrent myocarditis. The first one is on the definition, how to define a recurrent myocarditis. And the definition is quite simple, maybe a little bit broad, because it's new symptoms or disease activity after a clinical remission. And I think it is really important because it differentiates the recurrent form from a chronic inflammatory cardiomyopathy. And I think this is two different diseases. Patients that have an acute myocarditis that will have a recovery, full or not full, but that will have a recovery, and the patient that will have a complex evolution through a chronic form of an inflammatory disease. The second point is that to me, speaking about recurrent myocarditis is like navigating in unknown waters. And it is clearly highlighted in the last ESC guidelines. They highlight that there is a gap in the knowledge on recurrent myocarditis, and that there is an increasing body of evidence that there is an overlap between recurrent myocarditis and dilated cardiomyopathy, arrhythmogenic cardiomyopathy, inherited cardiomyopathy. And because I know that you are all very extremely knowledgeable in cardiovascular genetics and rare inherited disease, I wanted to start with a case of recurrent myocarditis without genetic. So this is the story of a 35-year-old woman, and she came to our hospital for a follow-up visit at 6 months. She was not admitted in our hospital during the index episode of myocarditis. So this patient had a very severe fulminant form of myocarditis associated with a viral infection. The PCR was positive for H1N1 influenza virus, and she had to be treated with to have an ECMO support during 5 days. She was treated with oseltamivir for the influenza virus, and she received corticosteroids. Unfortunately, the patient didn't get a biopsy, which is really questionable because she had a fulminant form of myocarditis. But at the end, she had a full recovery within 2 weeks with a normal left ventricular ejection fraction at 2 weeks. And she was discharged with the beta blockers and ACE inhibitors and referred to our centers to discuss the utility of genetic testing and to discuss the treatment. So during my consultation, the patient was fully asymptomatic. The physical exam was normal. The patient was still treated with ACE inhibitors and beta blockers. She had an MRI at 5 months showing a large LGE, 5 segment out of 17 on the inferior and lateral wall, and the LVEF was normal. She had also a stress test, completely normal. So the patient had 4 questions. First, should we stop the treatment? I have a normal left ventricular ejection fraction. I don't know why I have ACE inhibitors. So can I stop the treatment? And to be honest with you, my answer was okay to stop ACE inhibitors. And I decided to continue the beta blockers until we have the result of the genetic testing, because I consider that the large LGE was an indication to do a genetic testing. She asked me about the vaccination against the flu. And I answered, yes, of course you should be vaccinated. She was really afraid about that because she read on Google that there is a link between vaccination and myocarditis, and she was afraid about getting a new myocarditis once vaccinated. She asked me about sports, and she asked me about the risk of recurrences. And to be honest with you, I was struggling about giving a number on the risk of recurrences in fulminant myocarditis. 3 months later, I did a new TTE just to check that the LVEF was still normal after discontinuing the ACE inhibitors. Everything was normal. I had the result of the genetic testing. It was normal. And I was very reassuring for these patients. 6 months later, she was admitted for a new cardiogenic shock, again with flu symptoms 3 days before the admission. She had no extra cardiac signs. The LVEF was at 10%. She had an ECMO, a new ECMO, almost 1 year after the first episode. A PCR was positive for COVID-19, and the biopsy showed a lymphocytic myocarditis. And the question was, what is this disease? And I know that you are well aware about genetic and rare disease, but we had a positive antibody, anti-RNA polymerase III antibodies, which is something that is found in patients with sclerodermia. Patients with severe sclerodermia have RNA polymerase III antibodies. Which is interesting is that a series of patients with positive anti-RNA polymerase III antibodies associated with myocarditis has been published last year. This patient has no sclerodermia. They have no sign of sclerodermia, but they have a risk of recurrences about 38% of fulminant myocarditis without any known genetic background. And in more than 9 out of 10 patients, we found either COVID-19 or influenza virus. So I wanted to put the spotlight on this new entity in recurrent myocarditis, very particular because it's a fulminant form of myocarditis that will have recurrences. It affects mostly women. As you can see, there is only 17% of men with RNA polymerase III associated myocarditis. And if you look at your patient in your hospital with recurrent form of myocarditis, please do the test of the RNA polymerase III antibodies. Now, I wanted to share with you some words about the epidemiology of recurrent myocarditis. So we have 3 registries that have evaluated the risk of recurrences. The first one is an old registry, 10 years ago, 12 years ago, sorry. It's a registry where we don't know exactly if the patient had a myocarditis because it's just based on administrative data. There is no CMR, no biopsy, and the risk of rehospitalization for a new episode of myocarditis was 10%. In the Lombardy registry, which is clearly a higher quality registry with more than 400 patients, the recurrence rate was 2.6%. And in a recent French registry, 5% of patients admitted for a myocarditis had an history of myocarditis. So it's probably somewhere between 5 to 10%, the risk of recurrence. The factor associated with recurrent form in the Finnish registry were the length of hospitalizations. It doesn't mean anything for me, except that probably the complex form or the complicated form of myocarditis are at higher risk of recurrences. Patients with autoimmune disease, patients presenting with ventricular arrhythmias, and now after the presentation of Estelle, you are well aware that these patients are at higher risk of being carrier of likely or pathogenic variants, and the younger age. Let me show you some data not published yet. It has just been submitted last week, about recurrent myocarditis in the Amphibia cohort. So we have 600 patients with acute myocarditis. Among them, 80 patients had a recurrent form of myocarditis. And as you can see, the probability of recurrences increase according of the number of recurrences that have presented the patients. If you have a patient with already 2 or 3 recurrences, you are a risk of new recurrences approximately at 40%. And it was interesting to see that when patient had a recurrences, it's almost on the same, with the same presentation. Fulminant form will have a recurrence with a fulminant presentation. Uncomplicated form will have an uncomplicated recurrence. Patients with VA will have a new VA when they will have a recurrences. What was the factors associated with recurrent myocarditis in our cohort? And I think it's the largest cohort so far. So we had the positivity for anti-RNA polymerase III antibodies, the familial history of myocarditis, sudden cardiac death, or non-ischemic cardiomyopathy. And behind that, you can see that you have probably the fact of being to have a DSP or a TT invariance. Non-immunological disorder at the first episode. It was mostly lupus, sclerodermia. The age below 33 at the first episode was also associated with an increased risk of recurrences. And the fact to have an uncomplicated presentation was also associated with an increased risk of recurrences. It can be explained because these patients are more likely to have a DSP variant. When we look at the genetic testing, at the genetic test for recurrent myocarditis, so this is really preliminary data, and we have only 38 patients out of the 80 that have been tested. You can see that you can find a variant in desmosome genes, sarcomeric genes, sometimes TTR, so there is a wide variability of genes found in this recurrent form of myocarditis. But Estelle already presented this study, which is probably one of the best studies to illustrate the association between recurrence and desmosomal gene variants. As you can see, patients presenting with an acute myocarditis, when they have a desmosal gene variants, the risk of recurrences is up to 60% during the follow-up. So there is clearly a link. And I will skip this part because Estelle already presented this very small study with patients with history of recurrent myocarditis without a diagnosis of arrhythmogenic cardiomyopathy at baseline that have developed in the years to come an arrhythmogenic cardiomyopathy. What is the risk of event among patients with recurrences? It depends on the cause. As you can see, if you have a genetic variance and recurrent myocarditis, the study of Gasperetti and al. Demonstrate that you have an increased risk of events. I'm not completely agree with that based on our data, but it can be, of course, discussed. I have the feeling that more than the recurrences, it's the cause behind the recurrences that drives the prognosis. Having a genetic variance is different from having RNA polymerase III antibodies or having an idiopathic recurrent myocarditis or having recurrent myocarditis and lupus or sclerodermia. I think that it's fair to say that among patients with desmosomal variants, patients with recurrent myocarditis has an increased risk of event. So how to prevent the risk of recurrences? Of course, etiological treatment, if it is appropriate, in particular for autoimmune disease. I think that vaccination is really important for patients that have a recurrent form of myocarditis, always with COVID-19 or with influenza infection. But the key question that we all have is there a room for immunosuppressive therapy among patients that have presented 3, 4, 5 acute myocarditis, regardless of the genes? And when you look at the guidelines said that routine use of immunosuppressive therapy is not recommended among patients with preserved LV function. There is no mention of recurrent myocarditis, and there is a room for corticosteroids among patients with acute myocarditis and impaired left ventricular ejection fraction if they are refractory to standard heart failure therapy. This is mostly based on the thematic trial. And the thematic trial did not enroll patients with acute myocarditis. They enrolled patients with inflammatory chronic cardiomyopathy. This is not the same patient. So basically, we don't have any data. I think that the most interesting study is this one from Giovanni Peretto. Giovanni Peretto presents a series of patients presenting with myocarditis and ventricular arrhythmias. And if you have listened, Estelle, you believe now that a vast majority of these patients, or a subset of these patients, have a DSP variant. And these patients are at higher risk of recurrences. And when you look at how these patients were treated, they were treated with prednisolone, azathioprine, methotrexate. And when you treat these patients with immunosuppressive therapy, you reduce the risk of the PVC burden. So I know it's not exactly the same thing, but if you want to treat these patients, I think that you have to consider first to do a biopsy, because you don't have any evidence, any randomized trial, or even any registry dedicated to recurrent form to back up your practice. So I think the first step is to do a biopsy to be sure that it is a lymphocytic recurrent myocarditis, that you don't have any viruses that have a replication in the heart. And then you can share the decision of initiating an immunosuppressive therapy. From my point of view, corticosteroids is maybe not the right choice because if you decide to initiate an immunosuppressive therapy to prevent the risk of recurrences, you will start a treatment for months, years, and the risk of corticosteroids are all the side effects among a very young population. So in our network in France, most of them patients receive methotrexate. It's based on nothing, so I think it's really important to share this decision with colleagues, with the ERN network, and most importantly, with the patients. So what are the take-home messages on this presentation? The risk of recurrences, it's 5 to 10%. The genetic testing is mandatory. You have to investigate any immunological condition, and you have to keep in mind that sometimes you can have both diseases. Patients with recurrent myocarditis should be, for now, considered at risk of event for the years to come, in particular of VA. There is no validated or recommended treatment to prevent the risk of recurrences, and before initiating any immunosuppressive treatment, you should consider EMB, and you should share the decision with your patients. Thank you very much.
Thank you very much, Matthew. Very interesting presentations and very stimulating for discussion in some controversial issues. I agree with most of your consideration, with some exception on vaccination and globally, I agree with immunosuppression and the controversial issue in this specific setting of recurrent and genetically induced or genetics as main contributors of these inflammatory syndromes. So we are dealing with two cases, very interesting cases, I repeat. The first is a case of recurrent myocarditis in the setting of desmoplakin genetic disorder. And the second one is a case of genotype negative of recurrent myocarditis, probably in the setting of an immunomediated chronic disorders.
Exactly.
So the second case helped to interpret the data of a very wide range of recurrences from 5% to more than 30% of myocarditis when we are discussing about chronic immune-mediated inflammatory disorder. So all participants are invited to ask questions and share comments. Please. There are some questions from the audience. The two presentations are very representative of the critical notes and difficulties to decide in terms of therapeutic approach, prognostic stratification, sudden death risk. If there are no questions, I will try to make some question for Estelle. If I right understood, genetics in your presentation was discussed as a potential susceptibility factor for infection leading to myocarditis. However, you anticipate that we can consider an alternative second hit model where viral infection common in the general population act as a trigger that unmasks unmasks or accelerate disease expression in individuals with an underlying genetic substrate. I think that if I am carrier of a mutation of pathogenic or likely pathogenic value, I can have the possibility of a viral infection as in the general population. But my point of view is that the infection is not the main cause of the disease, but is the second it that from which start the expression of the genetic disorder. And in a paper published on the European Journal of Heart Failure on 2023, from the first name was Bassetto, in 17 cases there was different genes, mainly the desmosomal genes, but also filamin RBM20 desmin. And in that context, we found some apoptotic expression that without inflammatory changes, typical inflammatory changes, suggesting that probably out of the first episodes of myocarditis, the other one characterized by chest pain, troponin rise, but without any increase of C-reactive protein or fever or inflammatory expression, the patient could be a sort of repeat episodes of apoptotic damage that characterized the episodes. And so I would like to have a comment on the possibility that a pre-existing arrhythmogenic or cardiomyopathic vulnerability may be the main disorder, and the first episodes of myocarditis was just the trigger event. Could you comment, please?
Yeah, I think it's very important, and we have to better understand the pathophysiology of this inflammatory phase in patients with inherited cardiomyopathy, because as Mathieu said, it's important. We have to better understand that to know what kind of treatment we can propose to the patient. I think it's important to better understand that. To be frank, I think that probably the two different situations exist, because I think in some patients, the inflammatory that we observe is a kind of hot phase without any viral trigger of the cardiomyopathy. Because in some patients we did extensive diagnosis workout to look at virus. We look at in biopsy, etc. We didn't find anything that the genetic. But in other patients, sometimes you have a viral trigger, and there is two different studies showing that in animal model carrying a pathogenic variant, they have a higher susceptibility to different virus. So I think the two different situations can exist, and this is why I think we have to be very systematic, because as I show in the last case, the patient had Titin cardiomyopathy, but he has also viral trigger. He has, in some cases, you can have the relation of different cause that can trigger or increase the risk. And this is why I think we have to be systematic and to better understand also the trigger of inflammatory phase in this patient.
Yes, thanks. And on your presentation, I also totally agree that the coexistence of a genetic disorder, especially in the setting of desmosomes, filamin, lamin, desmin, RBM20, lower the threshold despite an apparently preserved or just mildly reduced ejection fraction, especially in the setting of extensive late gadolinium enhancement as the consequence of the previous myocarditis episodes. The coexistence, despite, irrespective of LV function, the coexistence of a substrate by magnetic resonance and a genetic setting, as we discussed, may lower the threshold, and for that decision, the family context, the arrhythmic burden, the extensive distribution of fibrosis, irrespective of LV function, may induce a protection with a defibrillator as a primary prevention. Matthew, there are several questions that you can check in the chat for your presentation, and probably is more quick to read and comment. The microphone, please.
You're
Please.
still.
Sorry. So the first question was, what did you answer to your patient about sport? So I authorized the sport. She had a stress test, a normal LVEF. There was no familial history of sudden death, cardiomyopathy, and I had no reason to think that she was at an increased risk of VA during sport. Just a quick word about that. When we look about the stress test of an all-comers population of acute myocarditis at 6 months, it was before the guidelines and the fact that we can individualize the duration of sport restriction. But when we look at 6 months, the stress test of an all-comers myocarditis, 80% of our population was deconditionated and was suffering from dyspnea because just they didn't do sport during 6 months. They are young, they are sportive. And I think it's really important to individualize this decision based on the presentation at risk or no. You had a VA at presentation, okay, no sports until you have the new MRI, you have the stress test, you have the Holter, you have the genetic testing. But in a patient without any electrical abnormality on the stress test, with an MRI, without impaired left ventricular ejection fraction, I think sports is okay. Do you recommend corticoids and immunoglobulin in the first episode of acute myocarditis? So, no, I do not recommend corticoid and immunoglobulin for a first uncomplicated episode of acute myocarditis. I think that among patients with a fulminant form or a very severe form of myocarditis, yes, corticoids are an option, and it's clearly mentioned in the guidelines. It's mentioned with a recommendation 2A if you have a biopsy with a virus negative PCR, and you have a recommendation 2B if you have a complicated form of myocarditis without mention of biopsy. So it's a possibility. For immunoglobulin, I think it has been evaluated among children mostly, not a lot among adults. Among children, there are a meta-analysis of the Cochrane that demonstrate that it can be useful. I think that the best spot for immunoglobulin are the very rare and very severe enterovirus myocarditis. So basically, if you have a patient treated with anti-CD20, rituximab, basically, think about immunoglobulin and do not put corticosteroids because corticosteroids are well known to be contraindicated in this situation, and immunoglobulin are the right treatment. So the most difficult question is the question for Madeleine Orban. How long do you treat a patient with immunosuppression for a recurrent form? I don't know, Madeleine. Probably for years, because when we look in our cohort to the median time before relapse among patients with recurrences, it was 2 years. 2 years between two recurrences. It means that if you decided to treat a patient to avoid the recurrences, you have to treat them for a long period of time. It's not just 3 months, 6 months. That's the key problem of the immunosuppressive treatment among these patients with highly recurrent form of myocarditis. It is that you have to consider this patient as having a chronic disease and to treat them accordingly. So it was the only question on the chat, Gianfranco.
The setting of immunosuppression remain at first episodes remain controversial.
Yeah, of course.
Probably in the setting of cardiogenic shock, out of hospital cardiac arrest, syncopal episodes, recurrent myocarditis, we have more data. But regarding the first episodes, we have to learn more for characterize and select the right patients for the right treatment. Probably when we decide to treat no less than 3-6 months, and for some patients in the setting of chronic immune disorder, more than 6 months, sometimes more than 12 months. So the time is out. I think there was a very important and stimulating meeting. A special thank to our speakers for their capacity, clarity, and generosity in share their experience, and your contributions are deeply appreciated. We hope this webinar has been informative and useful for clinical practice and research activities, and we hope to see you at the next session of the webinar series. Thank you all once again for your participation.
Thank you very much.
Thanks
It
a
was
lot.
a pleasure. Bye-bye.
To all three of you. Have a nice
Thank you.
evening.
Thank you very much.
Bye-bye.